Issues, so few minutes late. Are you all able to hear me? Can you please give me some feedback on the chat box? Am I audible? Okay, so today's class is titled Acute and Chronic Tonsillitis. A lot of changes in the hospital and college. One of the blocks is completely converted to COVID treatment, so we don't have our OPD area. That's why I'm a little bit late today. Okay, so I will be taking my class from a separate room. Hope there is not too much disturbance today. Anyway, so I will be putting up the PPT for access. There was some issue with uploading the PPT also, so I raised the issue with the concerned persons. Hopefully, I can give you access to all the recordings and PPTs shortly. Okay, so today's class we will begin. We will be discussing about acute and chronic tonsillitis, Vincent's angina, adenoiditis, diphtheria, and also adenotonsillectomy. Though the topic only says tonsillitis, there is no separate chapter for adenoiditis and adenoidectomy, so it will be covered in today's class. Today's class is important from the point of view that one of the cases which can be given in the clinical examination is chronic tonsillitis, and majority of the instruments and other discussion which occur during Viva will be about tonsillitis. So it's an important class, please pay attention, and any doubts you can clear the doubts. The important points to recap today will be the anatomy of the palatine tonsils. As you all know, the palatine tonsils are located in the oropharynx between the anterior palatoglossus muscle and the posterior palatopharyngeal muscle, which form the anterior and posterior pillars respectively. The surface of the tonsil is irregular, and there are pouches of mucosa which enters into the surface of the tonsil. These are known as crypts. The tonsil is supplied by ascending palatine and descending palatine artery, ascending pharyngeal artery, lingual artery, and facial artery, which give the respective tonsillar branches. The first pathology we will be discussing today is acute tonsillitis. Acute tonsillitis is a commonly viral infection. Several viruses have been implicated, such as adenovirus or rhinovirus, and now of course even coronaviruses. So sometimes there can be secondary infection with bacteria. Primary infection with bacteria can also occur in about 20 to 30% of cases. The bacteria which are implicated in this infection are streptococci, staphylococci, haemophilus, and diplococcus pneumoniae. Acute tonsillitis is more common in the childhood, that means less than 9 years of age, and it can occur even in adults, but it is less common. The spread of tonsillitis is usually by droplet or aerosol spread. They can be divided into types such as acute catarrhal tonsillitis. So in this series of pictures, the picture on top will be the acute catarrhal tonsillitis. Please give me a second. Okay, the first picture will be the acute catarrhal tonsillitis. You can see a diffuse inflammation of the oropharynx, and the tonsils are mildly enlarged. So there is no other distinguishing feature other than mild enlargement and flushing of the tonsils. The next type of tonsillitis is acute parenchymatous tonsil. The second picture, which is horizontally wider, is showing the acute parenchymatous tonsillitis. Here the tonsils are significantly enlarged and they come out of the tonsillar foci. In the picture, you can see both the tonsils are enlarged. The uvula is in the midline. You can also see part of the epiglottis inferior. The next type of tonsillitis is acute follicular tonsillitis. It's a severe type of tonsillitis. You can see white spots on the surface of the significantly enlarged and inflamed tonsil. And it can cause severe pain and difficulty in swallowing, usually associated with severe systemic symptoms as well, such as fever. And the last type of tonsillitis is the acute membranous tonsillitis, which is characterized by the formation of a white membrane on the surface of the tonsil. It is shown in the last picture. The symptoms will be sore throat, fever, malaise or weakness, odynophagia or painful swallowing, thick speech, typically the hot potato speech in the oropharyngeal lesions, and sometimes the pain can be referred from the oropharynx to the ear, most commonly in the follicular tonsillitis or when there are ulcers formed on the surface of the tonsil. The signs of acute tonsillitis can be systemic signs such as elevated core body temperature or pyrexia. There can be foul smell from the mouth, which is known as halitosis. The patient can have a furred tongue, enlarged congested tonsil, and other signs according to the type. The patient can have enlarged and tender jugulo-digastric lymph nodes. Jugulo-digastric lymph nodes can be palpated one finger width behind and below the angle of the mandible. Among these types of tonsillitis, the acute membranous tonsillitis has a significance because it can occur due to several other conditions other than just bacterial infection of the tonsils. The other conditions which can cause membrane formation, one is infectious mononucleosis. Can you tell me which virus causes infectious mononucleosis? Please type your answers on the chat box. There can be fascial diphtheria. It can be formed when there is an acute exacerbation of granulocytosis, that is in acute lymphoid leukemia or myeloid leukemia. It can occur with scarlet fever, oral thrush, Vincent's angina, and tertiary syphilis as well. But tertiary syphilis is very uncommon. I have not seen it. It is supposed to be having an increasing prevalence because of HIV resurgence. Yes, the answer is Epstein-Barr virus. Whoever answered Epstein-Barr virus, you are correct. Infectious mononucleosis is also known as kissing disease. It is common in older adolescents, and also it can be spread via shared utensils, such as in a canteen or a mess. Characterized by high fever and membranous tonsillitis. It is diagnosed by use of Paul-Bunel test. I think all of you are aware about this condition. So one of the conditions associated with infectious mononucleosis is Reis syndrome, which when aspirin is used along with during this condition, there can be a complication called Reis syndrome. So the treatment for acute tonsillitis will be basically bed rest, gargles of the throat. We usually use povidone iodine containing gargles, 1:1 dilution with water. Analgesics, NSAIDs can be used in severe pain. We can even use opiates such as tramadol, and antibiotics are used for the treatment of acute tonsillitis. So why do we use antibiotics? Though they are mostly viral, we use antibiotics for two reasons. One is to prevent a secondary infection. Second reason is to treat the bacterial infection, possible bacterial infection. We use a broad spectrum oral antibiotics initially. So earlier they used to use, as the slide indicates, penicillin V or benzathine penicillin injectable. However, these are falling out of favor because of complications of intramuscular injections and high prevalence of allergy to penicillin. Other antibiotics which can be used can be cephalosporins such as cefdinir or cefpodoxime. But the antibiotic, the first line treatment nowadays is amoxicillin with clavulanate. Amoxicillin, you should remember the dose, it is about 40 to 50 mg per kg body weight per day in divided doses. And usually in children we give 3 divided doses, in adults 2 divided doses if possible. Maximum dose is 5 grams per day for amoxicillin. In those who are allergic to penicillins, we can give clindamycin, which is very effective against staphylococcus. Other alternatives can be azithromycin or clarithromycin, but there is a high prevalence of drug resistance to these molecules. Therefore, they are not the first line of choice for treatment. Apart from treatment, before treatment, you should do something. What is missed out in the management in the slides? Something missed out? Okay, Nishanti says fluid intake. Yes, fluid intake is important because there is odynophagia. Sometimes patient goes for dehydration if they don't eat and drink well. So you have to maintain hydration by giving adequate amount of fluids. It's more important to pay attention to this component in cases where they have follicular tonsillitis, where there is severe pain. And in children, generally the child doesn't follow instructions, they stop swallowing, and then they go into all sorts of issues because of that. Yes, fluid intake. Anything else? Do you want to do any investigations before managing, or you just want to write a prescription and send the patient who comes to your clinic? Yes, one of the important specific investigations will be taking a throat swab for antibiotic sensitivity, culture and antibiotic sensitivity. So you have to ideally do this before starting any course of antibiotic for a seriously ill patient. Okay, so you can consider acute tonsillitis as a mild to moderate form of illness. Sometimes it can become severe if there is a complication. Before starting antibiotic therapy, always wise to do a throat swab for culture and sensitivity testing. Okay, so one variation of this type of testing which is available abroad is the rapid bacterial identification tests. Here basically you take a swab and then there are some kits available which immediately indicate whether it is a streptococcal infection or a staphylococcal infection. So it's important because streptococci can cause systemic complications. Okay, if for example, it can cause glomerulonephritis or it can cause rheumatic heart disease if there is a persistent or chronic streptococcal infection. So any possibility of recurrent tonsillitis with streptococci, you should be careful and you should treat it till the infection is completely gone. You should also watch for systemic complications. But in acute tonsillitis, maybe first episode, second episode, you may not be so worried about this in the initial stages. However, if the problem is untreated or doesn't respond to your treatment, it can go for complications such as peritonsillar abscess, parapharyngeal abscess, retropharyngeal abscess, laryngitis, and the suppurative lymphadenitis. So, peritonsillar abscess, as I mentioned in one of the previous classes, is also known as quinsy. It is the infection of the potential space which is between the tonsillar capsule and the pharyngobasilar fascia, and there can be collection of pus there with the bulging of the tonsil. We will be discussing it in the upcoming class. The infection can spread via the eustachian tube, causing acute middle ear cleft infection. It can persist, leading to chronic tonsillitis. There can be septicemia, and of course I mentioned the systemic complications of streptococcal infection. This is a photograph showing a quinsy. Basically, the tonsil is bulging medially and anteriorly, just as an example for a complication. Chronic tonsillitis is a condition which is characterized. How does it occur? This infection basically not a viral infection. Most viral infections resolve spontaneously without treatment by a period of 1 month, except for some specific viral infections such as hepatitis or HIV infection, which are chronic infections. Most acute viral infections of the oropharynx will settle down on their own. Maximum period is 1 month. If the infection is persisting beyond 1 month, then you have to suspect either some chronic viral infection or a bacterial infection. So, how does chronic tonsillitis occur? Chronic tonsillitis is a bacterial infection. It is a complication of acute tonsillitis. Basically, the bacteria invade into the body of the tonsil, leading to formation of multiple microabscesses, which are walled off by the fibrous tissue. And there can be intermittent release of the bacteria from the microabscesses, leading to subclinical infections without having a single acute attack. There will be recurrent or multiple exacerbations usually. It is common in children and young adults. Some predisposing conditions can be a focus of infection in the surrounding regions, such as chronic sinusitis or caries of the tooth. The patient will usually complain of very frequent episodes of throat pain. There can be foul smelling breath as one of the complaints. Cough can be caused by the irritation in the throat. So if the tonsils are significantly enlarged, they can obstruct the airway, leading to sleep apnea syndrome, which is a condition characterized by fall of saturation and repeated waking during sleep, leading to excessive daytime sleepiness and systemic complications. One simpler complication which can occur is snoring because of the turbulent airflow through an obstructed oropharynx. There can be vibration of the pharyngeal tissues, leading to a sound while sleeping. It may not disturb the patient, but the patient's spouse or other relatives or friends are usually affected by snoring. Sometimes it can be asymptomatic and it can become a septic focus, leading to systemic complications. Similar to the acute tonsillitis, the chronic tonsillitis can be divided clinically into chronic follicular tonsillitis, chronic parenchymatous tonsillitis, and chronic fibrotic tonsillitis. The pictures on the right show the three types of tonsillitis. In chronic follicular tonsillitis, if you see there are multiple small white follicles on the surface of the tonsil, the surface of the tonsil is inflamed, but the surrounding is not so edematous compared to the acute follicular tonsillitis. In this condition of chronic tonsillitis, if we press the anterior pillar against the tonsil using the tip of a tongue depressor, there is an exudation of cheesy white material from the tonsillar crypts or the crypta magnum, which are more at the upper pole. And this sign is known as Irving-Moore sign. The tonsils can be enlarged and irregular, leading to the situation of chronic parenchymatous tonsillitis. Sometimes, because of repeated inflammation, there is fibrosis of the parenchyma of the tonsil. The tonsil is small and lies within the substance of the tonsillar fossa, but there can be persistent inflammation. So, size alone is not an indicator of chronic tonsillitis. So, chronic tonsillitis have cardinal features or clinical signs. The word which is used is cardinal features. There are three cardinal features of chronic tonsillitis. So, one is Irving-Moore sign. Second one is flushing or congestion of the anterior pillar. Which part of the anterior pillar? If you look at the pictures, the first picture especially, you can see that the anterior pillar appears reddish, which is more in the superior pole of the tonsil. So, flushing of the anterior pillar, Irving-Moore sign, and enlarged jugulo-digastric lymph nodes are called as the characteristic features of chronic tonsillitis. In other words, they are the three clinical features with the presence of which indicates the chronic tonsillitis. The tonsils can be either large or small. That by itself is not a diagnostic feature of chronic tonsillitis. This is a picture to show the location of the jugulo-digastric node about 1 finger width behind and below the angle of the mandible. There are other diseases which can affect the tonsils. So one of them is Vincent's angina. It is caused by a spirochete known as Borrelia vincenti. The infection is insidious in onset. There can be fever and throat symptoms. The infection can be unilateral or bilateral, and there can be membrane formation sometimes. The ulcers are irregular, linear, and serpiginous usually. The diagnosis is by smear examination. Treatment is with penicillin. So not a very common type of tonsillitis, but it can occur. Why is it called angina? Angina means suffocation. It doesn't mean chest pain, it means suffocation. So the swelling in the throat mimics a sensation of suffocation. That's why it's called Vincent's angina. Okay, so we can use penicillin, otherwise sometimes even clindamycin or amoxicillin. What is Ludwig's angina? Ludwig's angina is a suppuration or cellulitis of the floor of the mouth. That is Ludwig's angina. It's a separate condition. It's not the same as Vincent's angina. Treatment for Ludwig's angina is also with the broad spectrum antibiotics. Tonsillar cysts are common benign conditions of the tonsils formed by walling off of the tonsillar crypts. So it can be left alone if it is not causing any problem. If the patient is symptomatic, usually they complain of a foreign body sensation or the cysts are growing in size. Then the treatment, definitive treatment is tonsillectomy. Sometimes we can attempt to marsupialize the cyst in the OPD by making a small nick on the surface of the cyst under topical anesthesia, but usually it recurs and the gold standard of treatment will be tonsillectomy. Tonsillolith is another complication. Basically, there is a inspissated secretion or food particles within the tonsillar crypts, which can become calcified over a period of time, leading to foreign body sensation in the throat. On palpation with a tongue depressor, there is a hard or gritty sensation, and sometimes we can manage to remove it with a probe in the OPD, but usually it cannot be completely removed, and the treatment again is tonsillectomy. One condition which is commonly confused with tonsillitis is keratosis of the tonsil. Basically, it's a benign condition. It's characterized by presence of horn-like or keratinous that deposits in the tonsillar crypts. It is characterized clinically with the absence of the perikeratotic inflammation. So just look at this picture on the slide. You can see the white keratin material within the tonsillar crypts. I'll just show you the follicular tonsillitis picture again. Okay, this is the chronic follicular tonsillitis. If you look closely at the picture, you can see that surrounding the white patches, there are regions of inflammation. There is a reddish ring around the white spots. So that is the characteristic clinical differentiating feature between the keratosis and the chronic follicular tonsillitis. There are many theories why it occurs, but basically it is a self-limiting condition, and sometimes it persists and it is harmless. Okay, it can recur in some individuals. The treatment will be with the frequent gargling after each meal to prevent accumulation of food, and you can even use, earlier they used to use Mandel's throat paint, which is nowadays no longer used. So it's a sort of an iodine solution which can be smeared over the oropharynx by the physician. There is one more tonsil which is called as pharyngeal tonsil or nasopharyngeal tonsil. This tonsil is located in the roof and posterior wall of the nasopharynx behind the nose. The common word used for this is the adenoid. Adenoids are normally hypertrophy. They start hypertrophy by the age of 3 to 4 years and they peak at around 13 to 14 years and subside by 15 to 16 years. And they may persist or enlarge even in adulthood, or they may cause symptoms which become the reason for treatment or excision of the tonsils. Just give me a second. Okay. Right. So adenoiditis can cause obstruction of the nose, which lead to the mucus collection in the nasal cavity and frequent cold. The child will have this characteristic appearance which is seen in the picture known as adenoid facies. Over a period of time, because of chronic adenoiditis, this can occur. What are the features of this adenoid facies? The nostrils look pinched and narrow. The mouth remains open and there can be dribbling of saliva and there will be mouth breathing. The teeth appear to be protruded, irregular and crowded. The lower jaw looks recessive, and in the oral cavity, if you look, you can see a high arched palate. The child generally has a dull look. Okay, so there is a reason for each of these. There are few common underlying pathologies. One is that because of nasal obstruction, there is an open mouth and mouth breathing leading to the inhibition of the midline palatal growth centers. This leads to abnormal growth of the midface. Therefore, since there is an inadequate growth of the alveolar arch of the maxilla, there will be protruding and irregular teeth, crowded teeth, and because of this midfacial growth dysfunction, there is a elongated midface vertically, and also because of the obstruction and apnea at night, there will be poor mental development leading to dull appearance of the child. The nose remains pinched and narrow because there is no airflow through the nose. So these are the features which are grouped together to form a constellation of signs known as adenoid facies. This is a common question in the examination. Apart from this, there can be changes in the chest, such as a pigeon-shaped chest, and there can even be a pot belly. The same reason, because in the right there is a obstruction to the airflow leading to the high negative flow and increased effort of respiration that leads to the formation of the pigeon-shaped chest and the pot belly. Pigeon-shaped chest means there is an increased anterior-posterior diameter. Pot belly means protruding belly. The clinical features of adenoiditis will be nasal discharge, facial pain or heaviness, epistaxis, that is intermittent nasal bleeding. Sometimes there can be rhinolalia clausa, which is known as denasal voice. So basically, close your nose and speak. What the type of voice you hear is called rhinolalia clausa. That is caused by adenoid hypertrophy. That is why sometimes even the parents, they ask us after surgery, will the voice change? The reason why is because the obstruction of the nose is relieved by the treatment. There can be associated eustachian tube obstruction leading to ear problems such as secretory otitis media, recurrent acute otitis media, or even chronic suppurative otitis media. Nasal complications include chronic rhinitis, sinusitis, and lymphadenitis can also occur. There can be bedwetting which doesn't improve with the development of the child because of the sleep apnea again. The hearing loss can lead to the poor growth of the child, mental development of the child. Now, how to diagnose this condition? The clinical features, the constellation of clinical features usually clinch the diagnosis. In a cooperative child, which very few of them are, you can attempt posterior rhinoscopy. That's in an older cooperative child. Most children you cannot do that. Under anesthesia, when you examine the child, you can palpate the nasopharynx. You get a characteristic bag of worms sensation of the adenoids. The diagnosis is usually done in the OPD by use of an X-ray, nasopharynx, soft tissue, exposure lateral view. It can also be diagnosed by use of endoscopes. Usually in the child we try to do with the flexible nasopharyngoscope. Otherwise we do with the rigid nasal endoscope also. So endoscopy visualizes the nasopharynx and gives us a clue to the diagnosis. Treatment in acute and mild cases will be conservative, consists of antibiotics for removing the source of infection, nasal decongestants temporarily, breathing exercises, steroid nasal sprays, topical steroid nasal sprays such as mometasone nasal sprays for a period of up to 3 to 6 months. The surgical treatment will be adenoidectomy for persistent and recurrent infection or complications of adenoiditis such as secretory otitis media. Along with the adenoidectomy, the common practice is to do grommet insertion to relieve the secretory otitis media. Other inflammatory disorders can also occur without adenoiditis, which can mimic it, such as acute nasopharyngitis, chronic nasopharyngitis, and one more condition called Thornwald's disease. There is a pharyngeal bursa, which is a vestigial remnant of development, which can get filled with fluid and develop into an abscess, which is known as Thornwald's cyst or Thornwald's disease. One condition you should be aware of as Indian medical graduates is phoceal diphtheria. Phoces means throat. So fascial diphtheria is an infection of the throat which is caused by Corynebacterium diphtheriae, which is a gram-positive bacillus producing exotoxin causing systemic complications of the cardiac and nervous system. It is spread via close contact or droplets, and humans are the sole carriers, more common in children, but it is rare today because of routine vaccination against diphtheria toxoid, which prevents the systemic complications. Therefore, it usually occurs as just as a normal tonsillitis and goes away without complications. The systemic features are because of the exotoxin, which cause fatigue, lethargy, tachycardia, and a toxic look. On examination of the oropharynx, you will find a grayish membrane developing on the tonsil, which extends from the pharynx, sometimes even on the surface of the larynx. There is associated generalized cervical lymphadenopathy or a bull neck appearance. So this photograph shows the bull neck appearance on the top left, followed by micrograph of the bacilli below and the oral cavity photo showing the membrane on the tonsil on the right side. Nowadays there is a anti-vaxxer movement abroad, so where people don't want to get their children vaccinated, and this can be one of the reasons why there is a resurgence of these conditions even abroad. This is another picture showing the grayish white membrane on the surface of the tonsils. So systemic complications you'll be learning into detail in pediatrics. What as a ENT surgeon we are aware of is that there can sometimes it can proceed to laryngeal airway obstruction by extension of the membrane into the hypopharynx. Diagnosis is by isolation of the organism using Albert stain culture on Klebs Loeffler media and or potassium tellurite agar. Treatment will be started before the culture confirmation. The important points to be noted are airway has to be secured and the child has to be resuscitated. If the child is in shock, you have to give adequate fluids. Then skin test for allergy to horse serum is done before administration of the antitoxin. So when you are giving it, one of the common complications is the systemic hypersensitivity reaction. So you should have epinephrine available. Before the antitoxin is made available, you can start off antibiotics also. The antibiotic of choice in this condition is penicillin G because there is very poor drug resistance in this condition. There is very few known cases where there is a drug resistant diphtheria. So the treatment will always be penicillin G in appropriate dose. Okay, the dose will be about 50,000 units per kg IV 12th hourly, along with horse antitoxin. Depending on the extent of involvement clinically, you can decide on the dose. So the dose varies from 20 to 40,000 units for single site to 1,20,000 units for multiple site involvement. The vaccine prevents the systemic complications. So we'll just go briefly look at adenotonsillectomy, which is the treatment of choice for chronic tonsillitis and adenoiditis causing complications. So tonsillectomy can be done when the tonsil becomes a focus of infection causing recurrent infection. That is at least 7 episodes in last 1 year or 5 episodes in the last 2 years or at least 3 episodes in the previous 3 years. It can be done as a procedure to approach the paratonsillar structures such as the lingual branch of the glossopharyngeal nerve and the styloid process of the temporal bone. It can be done for tumors of the tonsil to remove the tumor itself as a primary curative treatment. It can be done in sleep apnea syndrome to relieve the obstruction caused by the enlarged tonsils. It can also be considered as a prophylactic method when there is a streptococcal carrier state or HIV infection, but very unusual to use those as indications for tonsillectomy. It can be done when there is a focus of infection from the adenoid or tonsil into the ear. So adenoids can be done if there is a sleep apnea or recurrent otitis media or rhinosinusitis. So basically, if there are complications or developmental problems or significant loss of quality of life caused by the infection. If there is none of these indications, it's a single or a few episodes of tonsillitis or adenoiditis, you can manage non-surgically with antibiotics as discussed previously. In very young children below the age of 4 or 5 years, we prefer not to do surgical procedures such as adenotonsillectomy because there is a developing immune system. However, it is always a balance of risk and benefit. And if the child is going for severe sleep apnea or there is a loss of weight or systemic complication, even in a young child, we may have to consider adenoidectomy or tonsillectomy. Other relative contraindications will be anemia, bleeding disorders, hypertension, and diabetes mellitus, which are more in the adult age group. During episode of polio, we don't do tonsillectomy because it forms an easy route for the polio virus to enter and it can cause bulbar polio. Tonsillectomy is a very old procedure and it was traditionally done using the fingers, long fingernails. The surgeon used to grow the long fingernails, put the child's mouth on the lap, then put a finger and then just pull out the tonsil using the fingernail. Then the child used to bleed and then they used to pray for the bleeding to stop. Still in some uneducated regions, this is what they do. Then there was a dramatic improvement starting from the 19th century. They started developing instruments for removing it. So the first, initially they used to do something called tonsillotomy, and then intact capsule tonsillectomy, then finally dissection and snare method, which is today the gold standard of surgery. If time permits, we will see the surgical video also. So the modern methods include dissection and snare method. Guillotine method, recently it has been discontinued everywhere because of high incidence of bleeding. Electrocautery, cryosurgery, laser, harmonic scalpel coablation, and microdebrider can be used for tonsillectomy. In our institution, we do dissection and snare method. We also have coablation. We can use it in selective cases. Laser and harmonic scalpel are generally not used for this condition because of poor benefit. Cryosurgery, very little study is there. Microdebrider can be used for adenoidectomy. The position used is called rose position, where the neck is in extension with the flexion of the atlanto-occipital joint. After surgery, the patient is put in a lateral position, usually the left lateral position, so that any retained secretions in the throat can be drained out of the oral cavity. Complication of tonsillectomy is the most important complication is hemorrhage or bleeding. It can be divided into primary, reactionary, and secondary hemorrhage. Primary is the hemorrhage or bleeding occurring during surgery. It is prevented by good surgical technique, clean dissection, and it can be controlled by packing or pressure or by tying the bleeding vessels or by electrocautery. Reactionary hemorrhage is within 48 hours after the surgery. That is usually because of slippage of the knots. It is treated by gargling, and if the bleeding is not controlled, then we can take the patient again to the OT for again tying the bleeding point or cauterization. Secondary hemorrhage occurs after 5 to 8 days, usually after a week or two after the procedure, within 2 weeks. And during this occurs because of infection for the tonsillar fossa. Treatment is admission, IV fluids, and control of infection by systemic antibiotics. There can be trauma to surrounding structures during surgery, such as tongue, teeth, lips, and uvula, soft palate. There can be injury to the temporomandibular joint if the mouth gag is not properly applied. There can be aspiration of secretions and voice change, as I mentioned previously. So before ending, let me just try to play a surgical video. Just give me a second. In the meanwhile, if you all have any questions with the class so far, you can put it up on the chat box. Mm. I'm sharing my desktop. I hope you are able to see. Okay. Yes, you can see the surgery being done. This is the traditional method of adenoidectomy by curettage. After palpating the nasopharynx, under palpatory guidance, the central Thomson adenoid curate with cage is introduced, and under palpatory guidance, the adenoid is curated out. You can see the adenoid tissue being removed, right? So this is procedure is repeated by making sure not to go laterally. If you go laterally, there will be injury to the eustachian tube orifice, leading to long-term middle ear problems. So after curettage, the hemostasis is obtained by placing a gauze piece into the nasopharynx. The end of the procedure is confirmed by a characteristic gritty sensation which is obtained after curating the entire adenoid. So this is the classical procedure of adenoidectomy. Next we will be seeing the classical procedure of tonsillectomy by dissection and snare method. Yeah, this is the standard technique of tonsillectomy by cold steel dissection and snare method. I have recorded this video using a microscope in my previous organization. You can see that the patient in rose position with the Boyle Davis gag, and I'm grasping the tonsil with the Dennis Brown tonsil holding forceps. Incision is taken on the gray line where the mucosa flows from the anterior pillar to the surface of the tonsil. After taking the incision, so if you are oriented to this picture, the tongue blade which is shown on the top of the screen is actually at the lower end of the patient or the lower jaw of the patient, and the head of the patient is towards me or towards the lower end. Okay, so I'm using a tonsillar dissector to gently dissect or retract the mucosa till I find the plane of dissection, which is the peritonsillar plane or tonsillar capsule, which is shown by a whitish. There you can see I entered the plane. There is a whitish fibrous tissue which is seen. After entering the plane of dissection, I change the grip on the tonsil, and then I will continue the dissection. Yeah, so I have entered the plane of dissection. I change my grip and I will continue the dissection. Dissection is continued in a systematic manner, separating the anterior pillar, the fibrous bands between the tonsil and the tonsillar fossa in the middle, and the posterior pillar using a combination of blunt and sharp dissection. You can see the dissection going on. A gauze piece can be used to simultaneously press on the tonsillar fossa to absorb the secretions as well as give control of bleeding by pressure. Okay, so simultaneously controlling the bleeding as well as dissecting in the peritonsillar plane, we can separate the tonsil from the tonsillar bed. This is the sharp end of the tonsillar dissector. You can see the separation of the anterior pillar from the tonsil. Okay, then within the tonsil, we separate the fibrous attachments, and then posterior pillar we separate from the tonsil. Okay, that is separation of posterior pillar from the tonsil. So this way we systematically dissect the tonsil till the lower pole. Once we reach the lower pole, we use an instrument called Eames tonsillar snare, which consists of a 16 gauge piano wire. So the reason for use of the snare is because the lower pole of the tonsil is highly vascular, and the facial, lingual, as well as ascending pharyngeal branches of the tonsillar arteries, they enter from the lower pole, and they cause profuse bleeding if they are dissected in this manner. So to prevent that, we crush and cut the tonsil using the tonsillar snare, which releases the tissue thromboplastin and promotes the coagulation of the blood. So to control the bleeding and to separate the lower pole simultaneously, we use the Eames tonsillar snare. So I have reached the lower pole. You can see the leash of blood vessels entering the tonsil at the lower pole. And then now I will use a tonsillar snare. I will release the tonsil, then grasp it again and then pass the snare to the lower pole, and then with one fluid motion crush and cut the lower pole of the tonsil. There will be a snip and then the tonsil comes out. After the fossa is packed with a gauze and we leave about 3 to 4 minutes for hemostasis to occur. Then we remove the gauze and then check for bleeding using the pillar retractor of the tonsil. We retract the pillars. If there is any bleeding point in the tonsillar fossa, it can be controlled either by diathermy or by catching the bleeding point using the hemostatic forceps, first and second artery forceps. Okay, let me just go back. Right, so are there any doubts with today's class? I see something in the chat section. Let's see, I will take the attendance now. So hypersensitivity, somebody is asking how can you desensitize if there is hypersensitivity to horse serum? You will not have time to desensitize the patient if there is hypersensitivity, because it takes at least, even with the accelerated protocols, few days to desensitize the patient. So that is not an appropriate course of action to desensitize the patient. Okay, so membrane formed in Vincent angina and fascial diphtheria can be differentiated physically. So basically, the Vincent's angina, clinically differentiating is difficult, but in fascial diphtheria, what they say is you can peel off the gray membrane, leading into visualization of bleeding spots. Okay, so that is the characteristic appearance of fascial diphtheria. Maybe you can consider that rather than Vincent's angina. And Albert stain is a very simple test. You can do it and get the result within an hour in most laboratories. Okay. There was one more question. Let me just see. I'm not getting the last question which was typed. Yes, Manasa asked, can incision and drainage be included in management of acute tonsillitis? Incision and drainage is done when there is an abscess, not for an infection. Okay, so it is not the appropriate treatment for a tonsillitis. Please don't mention that. How is the release of tissue thromboplastin induced? Basically, you have piano wire which goes around the lower pole of the tonsil, and then there is a crushing effect. When we compress it, there is a crushing effect. When tissue is crushed, then there is a release of tissue thromboplastin. I hope I answered your question, Gambhir. Any other questions? If there are no questions, I will stop recording.